Hello and welcome to WHO and today's virtual press conference on global health issues. Apologies for our late start, but I hope we have an even bigger and better panel for that reason then. It is Wednesday, 4 September 2024, and we are here in WHO HQ in Geneva. My name is Christian Lindmeier, and I will take you through today's press conference. Now let me introduce the participants. Here in the room, we have Dr. Tedros Adhanom Ghebreyesus, WHO Director General, Dr. Mike Ryan, he's Executive Director for the Emergencies Program, Dr. Rogerio Gaspar, he's Director Regulation and Pre-Qualification. Then we have Dr. Maria Van Kerkhove, she's Director ad interim for Epidemic and Pandemic Preparedness and Prevention. Then we have Dr. Ana Maria Henao-Restrepo, she's the lead for R&D Blueprint for Epidemics. And last but not least, here in the room is Dr. Teresa Zacharias. She is the Incident Manager for Conflict Escalation in Israel and Occupied Palestinian Territory. We have a good number of colleagues also online, and very glad to be joined today by Dr. Rick Peppercorn. He's the WHO representative in the Occupied Palestinian Territory, and he's joining live from Gaza. Thank you for standing by. Dr. Hamid Jafari, he's the Director for the Polio Program at WHO in the Eastern Mediterranean region, and he's joining from Amman. Dr. Egmont Evers, he's the Incident Manager for the Sudan conflict and the refugee crisis. Then we have Dr. Philip Barbosa, he's Technical Lead on cholera. We also have Dr. Rosamund Lewis, she's the WHO Technical Lead for Mpox. And we have Tim Nguyen, the Unit Head for High Impact Events Preparedness. And last but not least, here online, we have Dr. Abdi Rahman Mahmoud. He's Director ad interim for Alert and Response Coordination. A very long list, as I said, and now we can head over straight to the Director General for the opening remarks. Dr. Tedros, please.
Thank you, Christian. Good morning, good afternoon, and good evening. First to Gaza. On Sunday, WHO and our partners began a polio vaccination campaign in Gaza. Over the first 3 days, we vaccinated more than 187,000 children up to 10 years old in central Gaza. Families have been eager to participate, telling our vaccination themes about children nearby who also should be vaccinated. Thanks to the community's active participation, health workers were able to vaccinate more children than expected. 4 fixed sites will continue to offer polio vaccination for the next 3 days in central Gaza to ensure no child is missed. WHO also provides supplies and training to health workers in areas not covered by the humanitarian pause to ensure children in those areas are also protected. Today, we're preparing the logistics, cold chains, teams, and communications to begin vaccination in southern Gaza tomorrow. We thank the health workers, UNICEF, UNRWA, and the many other partners and countries in the region and beyond who have supported this campaign. Together, we're helping to prevent the spread of polio in Gaza, but other health needs remain immense. We acknowledge that the humanitarian pause has been respected to allow the vaccination campaign to be conducted safely and successfully. We ask not only for that to remain the case, but also for a ceasefire. Now, an update on the Mpox outbreaks in the Democratic Republic of the Congo and neighboring countries. We expect the first delivery of vaccines to arrive in DRC tomorrow, donated by the European Commission's Health Emergency Preparedness and Response Authority, or HERA. DRC's Ministry of Health plans to begin deploying the vaccines this weekend. WHO is working with our partners to coordinate vaccine demands, share information on doses available, and ensure those doses are directed to areas where they can contribute to controlling the outbreak. I thank the European Union Commission for its donation And we call on countries with stockpiles of vaccines to work with us and our partners to get those vaccines to where they're needed now. We have also been supporting DRC and other countries to ensure the necessary cold chain systems are in place, to support communications campaigns to provide information about vaccination, and to counter mis- and disinformation. Vaccination is one part of the continental response plan that WHO has been developing with the Africa CDC and which we expect to publish on Friday. But vaccines alone won't stop these outbreaks. We're also working to strengthen surveillance, risk communication, community engagement, clinical and home care, and coordination between partners at every level. Today, WHO has published new data on cholera for 2023, showing an increase in both cases and deaths. The number of reported deaths from cholera last year increased by 71% compared with 2022, and the number of cases increased by 13%. Cholera killed 4,000 people. Cholera killed 4,000 people a year, a disease that's preventable and easily treatable. Conflict, climate change, unsafe water and sanitation, poverty and displacement all contributed to the rise in cholera outbreaks last year. The geographical distribution of cholera also changed significantly, with cases from the Middle East and Asia declining by 1/3 and cases from Africa more than doubling. Preliminary data show that the global cholera crisis continues into 2024, with 22 countries reporting active outbreaks. So far this year, more than 342,000 cases and 2,400 deaths have been reported to WHO from all regions. The global cholera crisis has caused a severe shortage of cholera vaccines. Between 2021 and 2023, more doses were requested for outbreak response than the entire previous decade. About 36 million doses were produced last year, only half the amount requested by 14 affected countries. Since October 2022, the International Coordinating Group, which manages emergency vaccine supplies, has suspended the standard 2-dose vaccination regime, adapting a single-dose approach to reach and protect more people with limited supplies. There is currently only one manufacturer of cholera vaccines, EU Biologics, and we thank them for the work they're doing to expand production. We urge other manufacturers planning to enter the market to accelerate their efforts and to make doses available at affordable prices. While vaccination is an important tool, safe drinking water, sanitation, and hygiene remain the only long-term and sustainable solutions to ending cholera outbreaks and preventing future ones. Finally, today, WHO is publishing a new framework to guide our member states in the studies that need to be performed to understand the origins of pathogens with epidemic and pandemic potential. Understanding when, where, how, and why outbreaks, epidemics, and pandemics start is extremely challenging. But it's both a scientific imperative to prevent future outbreaks and a moral imperative for the sake of those who lose their lives to them. The COVID-19 pandemic is the most extreme example of this in recent years. The framework published today has been developed by the WHO Scientific Advisory Group for the Origins of Novel Pathogens, or SEGO, a panel of independent experts which WHO established in 2021. I thank the chair of SEGO, Dr. Marieke Venter, and the vice chair, Dr. Jean-Claude Manguera, for their leadership, and all the members for supporting the work of SEGO with their time and expertise. The framework outlines 6 areas in which scientific investigations are needed to identify the origins of outbreaks: early investigations, human studies, animal-human interface studies, environmental and ecological studies, genomic and phylogenetic studies, and laboratory biosafety and biosecurity assessments. It stresses the importance of timely, comprehensive scientific investigations, of building research capacity, and the necessity of sharing results rapidly when they become available. This framework should be used by member states each time a new pathogen emerges. It would have been useful to implement when COVID-19 struck. However, even with a framework in place, it requires the cooperation, collaboration, and transparency of all member states. We still don't know how the COVID-19 pandemic began, and unfortunately, the work to understand its origins remains unfinished. SEGO is now finalizing its independent assessment of how the COVID-19 pandemic began. As I have said many times, including to senior Chinese leaders, China's cooperation is absolutely critical to that process. That includes information on the Huanan seafood market, the earliest known and suspected cases of COVID-19, and the work done at laboratories in Wuhan, China. Without this information, none of us are able to rule any hypothesis out until or unless China shares this data. The origins of COVID-19 will largely remain unknown. Christian, back to you.
Thank you very much, Director General. And let me now open the floor to questions from the media. And in order to get into the queue, please raise your hand with the raise your hand icon and then unmute yourself when it's time to do so. For the first question on my list here, it's for Daniel Lawler from the AFP. Daniel, please go ahead and unmute.
Hello, this is just a question for Dr. Tedros. I was wondering if you could comment on the contrast between how health workers carrying out polio vaccinations have seemingly been able to move around Gaza more freely and safely than other health efforts in the Strip, and why do you think that is? Thank you.
Maybe we use the opportunity to go to Dr. Rick Peppercorn, who's online. And Rick, please go ahead.
Yeah, so first of all, good afternoon and greeting from Gaza, from the WHO office in Deir al-Balah, where actually the emergency operation team actually is meeting just under me. So I understood the question partly, but I understood why do you think that we have this humanitarian specific pauses? Is that correct? Is that that's the question?
Yes, I'm just wondering about the contrast between how the polio vaccinations have been carried out, whereas it seems like it has been easier with Israel's help than other efforts such as supplying hospitals, for example.
Yeah, that's an interesting question. See, there might be, maybe there's various reasons. So first and foremost, I would hope that from all parties, we all agree that polio can be really easily be prevented. We have very good working vaccines for that. We don't want any child to get polio. I think that's a more general, a general feeling all over the world. Secondly, I think with polio, if you are aware, has been a public health event of international concern for many years, still is. And that has a reason. I think the world is on a track to eradicate polio globally. And we came far. There's only 2 countries where you have still wild polio virus, Afghanistan and Pakistan. And then in a number of places, you see this popping up, this so-called vaccine-derived poliovirus outbreaks. Now, so we are all, I would say, the global community is committed to that. We want to ensure, in this case, that polio, the transmission, that we stop the transmission in Gaza, and there will be no other Gaza children who actually will suffer from polio. But we also want to make sure that we prevent the spread from polio to neighboring countries all over. And you see, of course, these vaccine-derived polio outbreaks always in places where there's war and civil strife, when children are unvaccinated or under-vaccinated. That's the case in Gaza too. But I think your point is interesting. I think we should. And by the way, we are only on day 4 of this campaign. We've had 3 days, and as the DG described, fingers crossed, those were relatively good days. We're starting tomorrow in what we call the southern zone with a target of 340,000. It's more complex, but again, we need 3 days, and very much most likely we will need 3 plus 1 day in that zone, and then we will move to the north. So fingers crossed. There's an enormous amount of enthusiasm among the Gaza, the parents, the children, etc. That first 3 days went relatively well with all hurdles under incredibly complex circumstances, and all kudos to the 2,200 health workers, community organizers, but also all the planners, etc. I mean, people work literally from 6 in the morning till 11 at night to get this going under the circumstances. We need these humanitarian area-specific pauses to be respected. Otherwise, families, children will not be able to get their vaccines. And secondly, of course, those 2,200 workers will not be able to move. We talk about the south, more than 500 teams, 133 supervisory teams, a huge amount of fixed sites, etc. Everything is in operation, so we will continue. We keep going. And I think the last point I want to say, I am also concerned. I think we should learn some lessons if this works well. If this works well, what more would be possible? But I want to stress, I'm deeply concerned about the overall health situation. And I think the DG alluded to that as well. We see only 16 of 36 hospitals operational. We see less than 1/3, less than 50 of the 152 primary healthcare centers partially functional. We've seen an enormous spread in infectious diseases, more than 600,000 cases of diarrhea, more than 110,000 cases of hepatitis A, huge number of acute respiratory infection, dismal, horrible water and sanitary conditions, etc., and all combining to the spread of this kind of diseases, including polio. So all of that as well. And we still face the last 3 weeks, 2.5 weeks, WHO planned for 8 missions to the north to actually provide fuel, medical supplies, but also to get an emergency medical team out, and to get patients actually to do internal transfer of patients, medevac. And from these 8 planned missions, we only had 3 approved finally. And the last mission, remember when I was doing the second day of the campaign, the other WHO team was doing that job. We finished at 11:30 at night. We were deeply concerned because that team was still stuck in the north. And they only got out, they only arrived at our guest house at 1:30 in the morning. Now, this is what I would say, the average routine humanitarian operations by now, more than 11 months in this conflict. This should be routine. We still do not have or do not always have a working deconfliction mechanism, etc. So yeah, huge concern on the other ways, but I hope, and I want to close a little positive. I hope that we will learn lessons, that we are a little bit in a polio bubble, and I've never, well, for a long time, I haven't seen so many children smiling, happy, and by the way, explaining to me and to us why they wanted to be vaccinated. As there's a huge vaccination acceptance among the Gazans. They used to have, before the crisis, routine immunization coverage of 90% plus. That's higher than a lot of high-income countries. So yes, I want to end positive. We need to continue, and we need to make sure that we at least vaccinate 90% of the 640,000 children targeted, and repeat this feat 4 weeks later. Over to you.
Thank you so much, Dr. Peperkorn. Next question goes to Janice Koo from Bloomberg. Janice, please go ahead and unmute.
Hi, thanks very much. I just wanted to bring it back to Mpox. I'm trying to get a sense of whether the spread outside Congo is continuing. If there's a surge in Uganda and Burundi, if so, what that's looking like on the ground there, and if there's anywhere else on the continent that may be on the precipice of a surge.
Thank you very much. We'll start with Dr. Van Kerkhove, please.
Yeah, thanks very much. I can start. So I think, as we've said in previous press conferences and what we're doing in our briefings, is that we're learning. We're with enhanced surveillance activities, with detailed field investigations that are happening in the DRC, but also in neighboring countries. We're learning more about the spread of the different outbreaks of Mpox, which are caused by different clades. We have seen in DRC a rapid escalation, more than 20,000 suspected cases, but there's different epidemiology, there are different modes of transmission, there are different outbreaks that are happening in different parts of the country. That precision in understanding that epidemiology is really critical to tailor our response. We're also concerned about the increase in cases of clade 1b in Burundi. The latest data that I have in front of me on confirmed cases in Burundi was over 300 confirmed cases, 331. What's concerning about Burundi is that the cases are dispersed through the country. So we aren't seeing these small pockets of outbreaks. So this indicates to us that there's more transmission, there's more circulation that's happening. There are cases that are being reported of clade 1b in Uganda, in Rwanda, in Kenya, and there's been one exported case into Sweden and one into Thailand. With low numbers that we've seen, our challenge right now is having good visibility on the circulation of these viruses, which is why it's so critical that as part of the response, as you heard the DG say, vaccines are only one part of the response, strengthened surveillance, detailed field investigations, making sure that we have diagnostics in country is really critical for us to understand what is happening. But there are a number of countries that are at risk. Certainly we are seeing an increase in circulation in the DRC, particularly in the Kivus, but also a concerning situation in Burundi as well.
Thank you much. Thank you very much, Dr. Van Kerkhove. Next question goes to John Cohen from Science. John, please go ahead. John, do you hear us? If you can unmute yourself, please.
Sorry about that.
Yeah, you go.
Just to follow up on the same question, Burundi has more cases suspected and confirmed recently than anywhere other than DRC. What is the status of the country requesting donation of vaccine, having an EUA or some other mechanism to get vaccine? Does anyone know whether Burundi wants vaccine? And how would Burundi use vaccine given that targeted populations are unclear with the epidemiology?
Thank you very much, John. And this seems to be a question for Tim Nguyen. He's unit head for high impact events and preparedness. Tim, please go ahead.
Thank you very much for this question. I think the first requisite for most countries actually to access and request for vaccine is having the regulatory approval in the country prepared. And I think this is something that our colleagues in the WHO Regional Office and in the Africa CDC as part of the One Continental Plan are working with those countries to set up that system for the vaccine to receive. be receivable through a regulatory process. So I think this is the status at the moment where we are with the other countries in terms of supporting access to vaccines.
Thank you very much, Tim. I'm looking around the room if anybody wants to add.
Just to add to the information, we don't have evidence of a request from the country regarding using vaccines, but what we know is the country authorities are working to investigate and understand better the epidemiology and the chains of transmission, which is very important. And as Dr. Tedros says, this is equally important as to having vaccines, having all the other control measures in place, John, having contact tracing, understanding the groups who are at risk, implementing measures to reduce the risk of transmission, etc. So we continue to work with all the countries, and different countries implement the recommended WHO strategies using different approaches, and we value very much the efforts of the government of Burundi in understanding better the epidemiology. Thank you.
Thank you very much, both. With this, we go to the next question. That's for Kerry Cullinan from HPW. Kerry, please go ahead and unmute yourself.
Thank you. My question is related to cholera. The 70% increase in deaths over 1 year, given the relatively small increase in cases, is quite alarming. And I wondered whether somebody could explain what is driving these high deaths. Thank you.
Thank you. And I'm calling for Dr. Philip Barbosa. He's our technical lead for cholera. Philip, please.
Okay. Okay. Thank you very much for your question. So what needs to be understood is, the seasonality and the area that where strike is changing over the years. So, and also the way the different countries are reporting cholera cases is extremely variable across the world. And I think it's also an opportunity also to appeal for country to report more timely and more seamlessly the information that they have to ensure, as many are not doing it because of the fear of illegal sanction that are, of course, not recommended by WHO. So this is one of the parts which is challenging in interpreting data from different regions because the surveillance system are not necessarily comparable with one and another. So the difference in terms of pattern between the increases in cases and in deaths, and especially if you are comparing versus Africa versus the Middle East and Asia. In Africa, the surveillance system and the way that the country are reporting cases is, I would say, much more similar with one another. And in addition, there are a number of countries that should be praised for doing that are also reporting the cases and the deaths, more importantly, the deaths that are occurring in the community, so outside of healthcare setting. And this is a very important information because that really underlines how much people continue to die even before reaching any healthcare facility. And in some of the area, it can represent sometimes even more than 30% of the deaths that are reported globally. So by a country. So while in another country, the surveillance is more, based on symptomatology with less or more limited laboratory testing that allow to discriminate between cholera and other diarrheal diseases, and therefore the proportion of cases that are reported as suspect might be a bit higher, and therefore that can explain also why the CFR, the case fatality rate reported in this country would appear lower than a reality. But this being said, this is very technical. What we can draw from this conclusion is very clearly most of the very large outbreaks that the world has been facing in the past 2 years, and including this year and at the beginning of the year, are not only larger, more frequent, but they are very clearly deadlier. And this is something that the world needs to hear. We are in 2024. The treatment of cholera is extremely simple, extremely cheap, and people continue dying just because they do not have access to healthcare and very cheap treatment. It costs a few cents to prevent the death of a people, and this is a reality. So beyond the number of cases that are reported officially through notification system and and that have their limitation due to lack of support and investment. And we know, and we can say that we know that most of the cases are it's an under representation of the real number of cases and deaths that are occurring worldwide. Okay, so the estimation are much higher than that. It's the estimation that were made on modeling in 2017 was about 2 million cases a year and almost 100,000 deaths a year, a minimum. And that was before the start of the surge of the seventh pandemic. So beyond the figure, it's important to realize that, these tests are totally morally unacceptable, and we need to find ways to ensure that people have an easy access to treatment. And as reminded by the DG, that a long-term sustainable solution to this is providing basic access to safe water, basic sanitation and hygiene, and that will provide a long-term solution to prevent not only cholera, but all other acute diarrheal diseases. Over.
Thank you very much, Dr. Barbosa. Before we go to the next question, quick reminder. So I have now 3 more on the list here. That is Paul Adepoju from The Lancet, then Maya Plans from UN Brief, and Belisa Godinho, W Magazine. I'm saying that because we have apparently a reset of the hand. So if anybody else wants to raise their hand, and please do so again. And put you on the right name. So next question goes to Paul Adepoju from The Lancet. Go ahead and unmute.
Thank you very much. My first question probably goes to Dr. Hannah Maria regarding the research aspect of the Mpox response in Africa. I'm particularly looking at the focus for the Mpox vaccines, and available data, recent data on the candidate vaccines showed they've been recently extensively used in adults, but we have some countries in Africa where children are really the significant proportion for this. So what is the plan, and what does the approach look like in using these vaccines for children, and getting how this is going to affect future insight into how this vaccine will be used in future responses? Then the other question has to do with the multiple response to multiple outbreaks at the same time. For instance, we have countries like Nigeria that are dealing with Mpox, Lassa fever, and cholera at the same time, even though the public health emergency attention is coming to the Mpox aspect of this. But some of the responses to these different outbreaks can happen together. So is there a conceived intentional strategy to look at the ways that these multiple responses can be implemented together? Thank you very much.
Yeah, thank you for this question. We'll start with Dr. Henare Westheppel, please.
Thank you very much for the question. The first thing to say is that we have the pleasure of hosting with Africa CDC, USNID, and CEPI a conference on research on the 29th and 30th of last month. We have researchers from all over the world, but particularly a very important contingent of researchers and experts from Africa. And we discussed what the priorities for research will be, considering that research to be used as an additional tool to support the outbreak control efforts. And we are posting on the web the proceedings of the meeting, and also the recordings and the PowerPoint presentations for everybody to see. As you noted, there was attention to the priority questions for vaccines, and they could be aligned in 3 areas, grosso modo, that are very much in line with what our strategic advisory group of experts have highlighted. First is understanding how to best use the vaccines, what are the delivery strategies that are the best and most suitable for different epidemiological conditions. The second is understanding if we can use different schedules, different routes of administration, and what are the added benefits of that. And the third is on safety for the special populations. Now, on your question of vaccination of special populations, WHO published about a week ago our WHO position paper for orthopox virus vaccines. It reflects the recommendations of the Strategic Advisory Group of Experts meeting in April. And in summary, for infants, children, and adolescents, where consideration is given to vaccination in the context of outbreaks, considering the benefits and risks, a non-replicating vaccine like the MVA-BN or a minimal replicating vaccine like the LC16 vaccine may be used. LC16 vaccine is licensed in Japan for use in children. The MVA-BN is not licensed for use of children, so the use under this recommendation will be considered an off-label use. Because it's an off-label use, WHO and SAGE recommend that countries use this opportunity to collect information on additional safety profile. And I must say before I finish that it's not that we don't have data. There are already some studies of use of the MVA vaccine in infants and children, particularly observational studies and a few clinical trials. And in addition, a version of MVA using the same platform is used for Ebola control, and for which there is a big dossier of safety data. So in summary, you have to consider the risk-benefit. If you go for an off-label, collect information so that the data can be used to inform policy and regulatory in the future. Thank you.
Thank you very much, Anna Maria. And for the other part, let me see if Dr. Abdirahman Mahmoud, Director Interim for Alert and Response Coordination, is available. Abdi?
Thanks for the question. In terms of responding to multiple outbreaks, particularly in low middle-income countries, has been a challenge. WHO will develop the Health Emergency Preparedness and Response Framework that brings ability to respond to all hazards. We have seen multiple, as we discussed in Gaza today, in humanitarian situation, in addition to outbreaks. So we have a framework that deals with starting with community protection, because the community needs, as we are worried about Mpox, the communities outside there in DRC or Nigeria, the worry they have is measles, malaria, and other communicable diseases. So finding the balance, assisting the communities and listening to them, we start with that. So we have an integrated approach, bringing the surveillance, integrated response, and listening to the community. So the framework, or the HEPA frameworks, allows us to respond to multiple outbreaks that is going on. As my colleague, Dr. Barbosa, alluded, we have, in addition to Mpox in DRC, we have a large cholera outbreak that's currently under control for over 23,500 cases, and 314 deaths were reported from DRC, and most of them from North Kivu, South Kivu areas struggling with Mpox. So we have an integrated approach, responding to this crisis that are overlapping, stretching the community response. So we work with the ministries, and more importantly, local health clusters. We have 900 global members of the health cluster working with them, so that as we respond to an outbreak, we need to sustain the essential health services. So that's what we are doing, and working with the communities, starting with them as outbreaks ends, and start with the community.
Thank you very much, Dr. Mahmoud, and we have Dr. Mike Ryan to add.
Yeah, I think the questioner raised a really big issue, because it depends where you are in the world. Countries face different types of health emergency, but they all end up with people in hospital. They all end up with people in graves. They all end up with a health system that's overwhelmed. They all end up with the system collapsing around that. So designing response in a way that you can, as Abdi said, have integrated surveillance, integrated response, where you're trying to make the surveillance system, the community protection system, the healthcare system, the access to countermeasures system capable of dealing with whatever threat, be it in response to monsoon floods, be it in response to an earthquake, a conflict, or an epidemic. Gone are the days when countries could prepare for very specific threats, because many countries are facing multiple threats at any one given time. And again, if we take the example of DR Congo at this particular moment, the world is very, very concerned now about Mpox. There wasn't anybody jumping up and down last month, the month before that, about cholera, about measles, about meningitis. We raised these issues. With a vaccine that costs $100 a dose, $141 a dose, we want to vaccinate 5 million people in Congo, that's going to cost you $1 billion. If I had $1 billion tomorrow, would I be spending it on Mpox vaccine? Maybe I'd spend it on making sure my measles coverage is better, making sure my kids with malaria get treated. Countries face real trade-offs, real difficulties. So when you ask about Burundi, well, they're not requesting vaccine. Maybe Burundi hasn't requested vaccine. Maybe Burundi is considering what it spends its money on. The issue is Mpox has become an issue because it's seen as an international health threat, not because it's necessarily killing kids in a certain place. Same with polio in Gaza. The reason it's got the attention and we've got all of this cooperation is because it's a threat outside Gaza, not just to the children of Gaza. The world only wakes up when the threat is beyond the national border. And countries are left to deal with their national problems in national and sub-regional areas without any support most of the time. Sorry to be direct and difficult about this, but I think the journalist raises a very important issue. So we need to wake up and smell the coffee here. Many countries are facing multiple threats. They need assistance in developing generic, multi-capacity response mechanisms, not just when the world wakes up and perceives an international infectious disease threat like Mpox. Thank you.
Thank you very much for all your replies. Thank you. Next in line is Maya Plens from UN Brief. And as we have multiple colleagues still waiting, let's make this a short one, please. Thank you.
Thank you very much for taking my question, Christian. My question is unrelated to what we've been discussing so far, but it's something I have tried to get the media team to respond. It's because there is this conversation around the policies on alcohol consumption, wine consumption that the WHO issued last year. And apparently one journalist in the trade has done some research and discovered that there is influence of some NGOs, groups that are actually not very well due diligence perhaps wasn't done before, but they seem to have influenced these policies. And I would like, my question is, who do I speak with and where are we at this conversation since the issues of these guidelines saying that there is no safe level of alcohol consumption, when we know in many cultures in Europe, in particular, moderate alcohol consumption has been improved in many studies. That they are good for the health of women, cardiovascular health.
Thank you very much, Maya, for this point. We'll get back to you on this through the usual channels. Now let's take a question which fits into the realm of this press conference. Next question goes to Belisa Godinho from the W Magazine. Belisa, please go ahead.
Hi, I would like to, if possible, to have the confirmation if Mpox virus could be related to or is related with climate change. If so, I ask whether if the prevention of the disease and others affected and aggravated by the climate should not be carried out alongside the fight against the virus and global warming. Thank you.
Belisa, if we understood well, the second part, whether this is a multifactorial approach and there should be other ways to tackle it than just the virus, right? So, but over to Dr. Van Kerkhoff, please.
I think maybe just in general can say there is a link between climate change and risk of infectious diseases. We're seeing changes we can give multiple examples of how climate change is affecting the geographic distribution of vectors, for example, for Aedes-borne viruses like dengue, like chikungunya, where we see vectors able to thrive further north and further south of the equator, impacting billions of people around the world. We do see changes with climate change, with El Nino, El Niña, the way animals move on the planet. We've seen this with wild bird patterns. And avian influenza, for example. If you look at the freeze-thaw patterns of lakes and large bodies of water where these animals rest as they navigate and move around, migrate around the world. Specifically with regards to Mpox, we are looking at, as part of the Global Strategic Preparedness Response Plan, not only stopping human-to-human outbreaks transmission, but also looking at spillover and reducing zoonotic spillover. And this has to do with the way people live and how they hunt and how they consume wild animals. There's a lot of efforts underway that can look at how we address the drivers of spillover. And of course, that's linked to climate change. So there is a direct link there. And for us, what we need to be able to do is to holistically look. It's not about dealing with pandemic preparedness or climate change. It's about how we collectively approach this. This is actually being discussed, as part of the pandemic accord. It's discussed constantly here with WHO and all of our partners of how we work together to address all of these multiple drivers because they are directly related.
Thank you very much, Dr. Van Kerkhove. Next question goes to Yan Zheng from Xinhua. Yan Zheng, please go ahead and unmute.
Thank you. My question is, could the WHO share with us the latest developments concerning the emergency license process for the Mpox vaccine, and what are the main bottlenecks hindering that process? Thank you.
Thank you very much. Rogerio Gaspar, please.
Okay. Thank you. So, as you know, we have opened the emergency use listing opportunity for expression of interest even before the expert committee for IHR recommended the Director General for the declaration of the fake. In recent weeks, we have been in close contact with manufacturers, both on the vaccines and on the diagnostic side. We are currently reviewing 3 vaccines. It's already known, MVA Bavarian Nordic, using as a reference authority the European Medicines Agency. But at the same time, we are discussing with KM Biologics from Japan on LC16, as it was referred before in answer to another question. And we just had today a meeting with Emergent on the ACAM 2000 vaccine. These 3 vaccines are recommended by the SAGE since April. They configure different platforms and different situations. From the regulatory perspective, MVA Bavarian Nordic fits the requirements for pre-qualification. So currently, we are not assessing it under emergency use listing, but under full pre-qualification. We anticipate if the questions that were put to the company are answered this week, we might be able, on the best case scenario, to conclude the evaluation during next week. This is our anticipated best case scenario. With LC16 from KM Biologics, we are in the situation of reviewing the file and putting the first round of questions. And we have convened a technical advisory committee for the EUL before the end of the month. And the recent discussion that we had today with Emergent Technologies on ACAM 2000, most probably there'll be a first submission of data before Friday this week, followed by a new meeting next Tuesday, and the potential submission either the end of next week or the week that follows. So we are looking at these situations with 3 different pairs of eyes, because MVA Bavarian Nordic, as I said, it's very close to the final approval. LC16, we are still reviewing data that is being submitted. And with ACAM 2000, as it was highlighted in April by the SAGE, we have a number of concerns on safety on special populations. This was discussed openly with the manufacturer, and we had a meeting with the FDA, that is the reference regulatory authority for this one, last Monday. We are concerned about the implementation of safety monitoring on the deployment of the vaccine. So a final decision on ACAM 2000 to be pre-qualified, even though it was approved by the FDA, or to go through an emergency use listing, looking at the data that needs to be collected after approval, will be taken only after the submission of relevant data that we have to review. I think this is the full information I can disclose at this moment. Thank you. Sorry, on the diagnostic side, we have 4 expression of interests, and I would say that 2 of the submissions are very close to progress. I have a huge amount of detail that was prepared by the relevant team, a huge amount of work being done in the diagnostics in recent days. We hope to move as soon as possible to have also a number of diagnostics emergency use listed. As we know, this is absolutely essential on the response and the follow-up of the epidemiology of Mpox to have relevant diagnostics. Thank you.
Thank you very much, Dr. Gaspar. We are running now close to time, but we may have time for one more question, and that goes to Politico for Rory O'Neill from Politico. Rory, please go ahead and unmute.
Hello, thank you. I have a question about the Bavarian Nordic Mpox vaccine. The EMA has advised that countries might want to administer it as an intradermal injection, which might allow doses to stretch up to 5 times further. A couple of European countries have emphasized that when announcing their own donations, but I was wondering if WHO has a position on that.
I refer again to the 2 documents I mentioned before, the SAGE recommendations and the WHO position paper. These documents include the review of the evidence for alternative routes of administration, including intradermal,